Hi, everyone. Welcome to the Advancing Implementation Science for Adolescent HIV in High Burden African Countries satellite. I'm Rachel Stirk. I'm the Acting Deputy Director of the Fogarty International Center and lead the Adolescent HIV Implementation Science Alliance, along with my colleague, Susan Vorkoper. So to give a little bit of context, across the world, health systems are challenged with how to adopt, integrate, and scale up proven public health interventions. Implementation science plays an important role in identifying barriers to and enablers of effective global health programming and policymaking, and leverages that knowledge to develop evidence-based innovations to effective delivery approaches. Yet support for implementation research alone will have limited impact unless it's accompanied by efforts that facilitate use of scientific evidence by health program implementers and policymakers. Indeed, implementation science requires partnerships between diverse stakeholders, policymakers, program implementers, and researchers to ensure that the science addresses timely and relevant policy and programmatic implementation challenges. This session will give insight into the learning from the Adolescent HIV Implementation Science Alliance, or AHISA. AHISA convenes a forum of implementation science researchers, policymakers, and program implementers from in-country to enable the exchange of ideas, insights, and experiences in understanding factors that drive uptake and adherence to adolescent HIV prevention and treatment strategies to bridge the gap between research, programs, and policy. This session builds on the presenter's experiences in AHISA and presents the findings of a special supplement in the Journal of AIDS and Behavior that reflects the collective learning and experience of the Alliance teams with respect to the application of implementation science in the context of adolescent HIV. The supplement contains 13 articles with topics identified by AHISA members. 20 of the 26 teams participated in at least one article, and the supplement has 40 AHISA authors overall. Themes of the supplement were varied. Many of the articles assessed the current academic landscape related to HIV and implementation science generally, and specifically to AHISA, highlighting the use and utility of implementation science frameworks, methods, and outcomes, and considered how these findings connect to access and utilization of testing and treatment and optimizing integrated health services. Several of the articles specifically focused on timely topics, including, for example, adaptation of research and practice in the context of COVID, as well as use of innovative technologies. While all articles centered on adolescents and young adults, a number of them explore opportunities for implementation science to enhance adolescent-specific approaches to the prevention and treatment of HIV. These included best practices in adolescent engagement in terms of meeting youth where they are, tailoring programs, and peer support, as well as mental health and intersectional stigma. So finally, congratulations to the teams and the network overall for a truly remarkable product. And now I'll turn it over to panel one.
So welcome everyone to panel one. This is where we're going to talk about the use of implementation science to address adolescent HIV prevention and treatment in Africa. My name is Nadia Samagudu. I'm an associate professor of pediatrics at the Institute of Human Virology at the University of Maryland, Baltimore, and also the senior technical advisor for pediatric and adolescent HIV at the Institute of Human Virology, Nigeria. And with me today, we have 5 panelists who are all members of AHISA who are going to discuss different topics with respect to the papers that we have in the AHISA supplement in AIDS and behavior. We'll start off by introducing Dr. Kristen Benmasofi, who is a senior research scientist in the Department of Global Health at the University of Washington. She's a qualitative researcher within the fields of behavioral and implementation science, whose research interests have coalesced around understanding factors that influence the health of women, children, and adolescents impacted by HIV. Kristen will be talking about addressing the no-do gap in adolescent HIV in terms of the work that AHISA network has been doing. And then we have Dr. Joe Tucker, who is an infectious diseases physician and public health researcher at the University of North Carolina. He is interested in crowdsourcing and related participatory methods. His special issue topic focused on using crowdsourcing to identify adolescent and young adult engagement strategies. Next, we have Dr. Jerry Donnenberg, who is a professor and directs the Center for Dissemination and Implementation Science at the University of Illinois, Chicago. Next, we have Dr. Suja Subramanian, who is a senior fellow and senior economist at RTI International. Her paper was focused on integrated healthcare delivery for adolescents living with and at risk of HIV infection. And it's a review of models and actions for implementation. And then we have Dr. Laron Nelson, who is the Independence Foundation Professor of Nursing at Yale University. His research focuses on multi-level equity-focused implementation science approaches to optimizing the impact of biomedical HIV prevention innovations in the United States, Canada, and Ghana. So a hearty welcome to all of our panelists, and thank you so much for being here. And so what I'd like to start off with is asking each panelist to briefly describe your article topic and the major findings. What is a punchline? What is the message that you want to get across from your paper and your study? So we'll start with Kristen.
Thanks, Nadia. Great. All right. So for our article, for the review that we did, we kind of went back to the very first AHISA meeting where we had all brainstormed as a group what our goals for the Alliance were, which just as a quick reminder are to build implementation science capacity among AHISA members, develop an implementation science research agenda, and then to build a sustainable platform for future collaboration that would help move adolescent-focused HIV interventions into practice. And so one of the ways that we thought we could help address this agenda or move this agenda forward was to really characterize the implementation science landscape within our ongoing AHISA-affiliated project. And so the goal of this review was to kind of evaluate and understand how AHISA teams are thinking about these concepts in practice. So what are AHISA teams doing? How are they measuring implementation outcomes? And then what kinds of implementation strategies are teams using in practice? So we solicited protocols and protocol papers from all of the AHISA team members. And we received 1 to 3 protocols or study papers from each of the different member teams. And then we went through and characterized those protocols to pull out and extract information on study context. So thinking about study design, populations, and geographical settings, looking at the types of evidence-based interventions that the study teams are using, and whether or not they're evaluating clinical or efficacy or effectiveness outcomes, and which ones, and then looking at specifically which implementation science outcomes are being measured, whether or not they're measuring implementation determinants, and then also whether or not they're testing different implementation strategies. So we ended up having studies submitted that represented 10 different countries. Overall, most of our studies, or about half of them, focused on HIV prevention, about 30% focused on HIV treatment, and the rest were on HIV testing. All studies measured both clinical outcomes and implementation science outcomes. And really what that represented to us was this reliance on hybrid effectiveness implementation study designs, most focused on early implementation outcomes, things like acceptability, reach, and feasibility. Less of the studies looked at actually assessing determinants of implementation, and we found that only 53% of studies actually used or relied on an existing theory model or framework from the implementation science space. We also found that most of our studies were looking at some sort of implementation strategy, some developed and tested strategies, while others kind of adapted existing strategies. Kind of our conclusion or kind of overall thing is that we can really try to focus some additional energy and look at kind of later stage implementation science outcomes, how we think about measuring and testing strategies, and then also what the use of theories, models, and frameworks might look like in the future and how we can build capacity to kind of use those and harmonize language across different studies.
Great, thank you, Kristen. So it's, the exercise that you and your team did was really good for setting the tone, sort of doing a profile of everything that AHISA has been doing, what we are doing well, what we are not doing not so well, and how we can provide more rigor in our studies. So this is a very good sort of first look into what AHISA has been doing, and then gives us the opening pathway to talk about things in a bit more detail. So now I want to ask Joe to tell us about his study and how AHISA had been doing crowdsourcing in terms of implementation science for adolescents living with HIV. Joe?
Thanks, Nadia. And actually, from Kristen's really nice AHISA study, our Nigerian study was one of those studies and focused sort of on crowdsourcing. And then we thought, well, gosh, there's so many ways that young people are engaged. Wouldn't it be interesting to do a crowdsourcing open call and just capture the richness and the nuance of adolescent engagement in research? So that's what we did. Across Africa, we had an open call. We formed a steering committee. Each of the submissions was judged and finalists were recognized. We ended up getting 95 submissions from 15 countries. And there were a couple of themes that were interesting. One was that young people were engaged in community level capacity building efforts. So training and peer support, peer navigation. And AYA, or adolescents and young adults, are also engaged in low risk behavioral research. So this is the kind of study that they could really lead. Young people were involved in co-creation activities, so youth and researchers working sort of hand in glove, really in close partnerships. And then also some great innovation around digital methods. And this was sort of higher tech digital, as well as simpler things like USSD and low bandwidth digital solutions. So we were really impressed with how youth were engaged across the spectrum in different African settings, and this really supported sort of a larger role for youth in terms of implementation science studies.
Thank you, Joe. So Kristen helped to sort of set the tone in profiling what the AHISA research teams were doing, and this Joe's paper was able to tell us what are we doing with adolescent and young adult engagement, and when they are engaged, to what degree are they engaged in, and what are they doing, and at what levels of research are they being involved. And the study around this itself was a crowdsourcing approach that was inviting adolescents to tell us how they were being engaged in these studies. So we look at the researchers on one hand, and then we look at adolescents on the other hand, and how we are working with them in these implementation science studies. So excellent. And so next I'd like to ask Jerry to tell us more about the work that she and her team did for this special issue.
Yeah, thanks so much, Nadia, and thanks for the invitation to be part of this important panel. Our work in this particular paper focused more on dissemination of evidence-based interventions, because there are a number of interventions that we know work. And but in order to really achieve a public health impact, we really need to figure out how to distribute that information and spread the knowledge about these evidence-based programs so that people can use them and for more public consumption. And there really is sort of a lack of a systematic body of research that on theories and frameworks for dissemination. So we took the opportunity to present what we see as the barriers to dissemination of evidence-based programs, and we characterize those as sort of communication barriers and researcher accountability barriers, and the fact that it's very important to do planning for dissemination early, and that another barrier are kind of resources. So in terms of communication as a barrier, we aren't very good as academics at publicizing what we do and tailoring our messages for audiences specifically that we want to target, and using convincing messaging for those specific target audiences and context. When we publish our work, that information isn't reaching the frontline implementers. And we also often think as researchers that we're not accountable for the dissemination piece, that's someone else's job. So we silo that. And yet we're very important to that dissemination, because we know best what how that evidence-based intervention was developed, for who it works best for. And then in terms of resources, we know that dissemination really requires an active push out of information, but time is rarely built into our projects for personnel or resources to facilitate that active push out. And as well, agencies often are not building in time for their staff to go looking for innovations. And so with those sorts of barriers, we thought about a blueprint that USAID has published or has developed for helping researchers disseminate their information and tailoring it to use more persuasive communication messaging for their audiences. And they presented 7 different strategies that would be useful for dissemination. And the 2 that we focus a lot on in the paper is creating a technical assistance dissemination team and really engaging them early on in the process to help researchers disseminate this information, develop the products that they would use to disseminate information, how they would tailor it to different audiences, funders, community, stakeholders, policymakers, and so forth. And then also to do planning in advance so that when you get to the end of a study, you've already built in a dissemination plan. So our final lessons that we report on in this paper, in this commentary, is that the use of digital tools can be very helpful for dissemination, that, like Joe was referring to earlier, that if we can include youth voices in dissemination, it's more relevant to the people we're trying to target, that we need, as we're thinking about dissemination, to consider the context and its evolving priorities, that really we need partnerships and teamwork in terms of how to disseminate, really working with other individuals for whom that's their expertise, dissemination, develop human-centered design, how to develop communication products that will be effective. And then the last 2 would be making sure that we include in our budget opportunities for active pushing out of disseminating evidence-based programs. And then lastly, there's really a lack of rigorous measures that can evaluate our dissemination efforts. So thanks so much for inviting me.
Absolutely. And thank you, Jerry. You know, you are absolutely right. When we do start, especially when we get into implementation science, implementation research, at the beginning or for a long time, we tend to really ignore the dissemination part, which is why the name dissemination and implementation science actually sort of wakes you up to the fact that, you know, the dissemination is not married from the implementation, because part of the no-do gap is a dissemination issue. Part of the no-do gap is not an implementation thing, it's a dissemination thing. People don't know about it. How are they going to use it if they don't know about it? So this is very important. And thank you for also mentioning digital methods for dissemination and the importance of having good measures of dissemination, or the extent of dissemination, or dissemination success. So thank you so much. So next, we're going to ask Suja to talk about their paper, which was focusing on integrated healthcare delivery. Suja?
Great, thanks, Nadia, and wonderful to hear all the work that's being done, although I've reviewed the papers. And I'm thrilled to be here to present on behalf of a large team that actually worked on this manuscript. And just before I even get into the topic, just to say that having the ability to bring together, we were representing 7 different countries in sub-Saharan Africa and 1 actually in Brazil. It was great to have a diverse viewpoint. So because part of our strategy was try to address and try to understand sort of the diversity and try to implement in the multiple settings that we do, which are all quite different. But the topic and the gap we were trying to address was trying to understand what is the best way to implement sort of an integrated model. Because as all of us know, the adolescents and young adults that we work with, their needs are not just HIV focused, whether they're living with HIV or whether they're at risk of developing HIV. It's sort of a lot of different services, including, especially for both, I think, for our young women, young men, girls and boys, it's reproductive health, it's front and center, mental health services, and other things that we were trying to embed as well, such as cancer screening. So the needs are broad, and we were just trying to figure out what is the model that is effective and can be sustained. So we began a broad scale discussion, and we realized very early on we needed a framework because we were talking across each other, but weren't really trying to have a consistent kind of even, I guess, definitions of what we were talking about. So that's how we developed a framework, which is called the AIMS framework, which is the Adolescent Focused Integrated Modular Services. And the reason for the term modular is part of our discussion across these countries and across individuals with various backgrounds. We realized no one size fits model is going to work everywhere. So it had to be modular in the sense that some programs were focused on one area of integration, whereas others were focused on other. Some wanted to do a multi kind of service delivery model. So that's why the term modular was very important and added into the framework. And our model consists of, I guess, the first domain or pillar is really the socio-ecological model. We are just acknowledging that there are multiple levels here. You know, it's not adolescents clearly front and center, their families, providers, the system, etc. The second pillar in our model was community clinical linkages, really to understand that services are a continuum. Some of it can be in the community, especially all the strategies that we work on from an educational perspective, etc. You know, much of it is delivered in a community setting, but we really understood the importance, I guess, of linking it to the clinical setting because we didn't want to miss that, especially for things like reproductive health services. Some of it had to be offered in a clinical setting. And then lastly, our last pillar is obviously the important one, which is just adolescent-focused care. We were embedding the WHO model into our framework, but also very focused on measuring the outcomes as well related to adolescent-focused care. For example, are adolescents actually included in the discussions? I know we've heard that from the other speakers. Of course, it's important, but whether it actually happens and to what extent. And so those are the factors we included. We did review 10 programs across sub-Saharan Africa and Brazil. And what we found that although HIV outcomes were very well established and really looked at in rigor, implementation outcomes or even implementation determinants, and then moving on, adolescent-focused outcomes, and then economic outcomes were not really well thought through or really built in. So we had recommendations about using our framework as well as measures to move the field forward. So I'll stop there and back to you.
Thank you so much, Suja. You know, as you're speaking, I'm like, I really need to pick up on that model and use it in the work that I'm doing in Nigeria and across West and Central Africa, because we haven't had very good guidance for integrating services, let's say within HIV, but particularly for adolescents and young people, because in some places the services aren't even well characterized. In some countries, adolescent health services weren't specially put together or weren't specially designed until HIV came in, until we started responding to HIV. So really, adolescent HIV services are setting the tone for how other adolescent health services are being implemented. And of course, another thing we're learning from here is that besides dissemination, integration is a very important aspect of implementation science, because it helps with the efficiency of service delivery and to increasing access of the clients that we are talking about, or the clients that we are focused on, to not only one service, but multiple different services provided in a comprehensive manner. So thank you to your team, to you and to your team for the excellent work that you've done. So last but not least, we are going to ask Laron to tell us about his paper, which was really quite unique in that it's talking about using the implementation research logic model to look at HIV implementation and care interventions among adolescent sexual minority men. Laron?
Hey, thank you. So the team I work with was really interested to understand what we can learn to help promote implementation science in ways that can really benefit HIV outcomes for sexual minority youth. That's something that there's a big gap in across the globe, but particularly in African context. And so we took the opportunity of this existing, network of AHISA and PATCH to try to understand what are the implementation science processes. We wanted to compare those, and we used the implementation research logic model and CFIR, the Consolidated Framework for Implementation Research, as sort of two lenses to understand what is it that people are doing or have done. We decided to apply this in a multiple case study. So we took 10 cases that were drawn from across 5 countries. That was Ghana, Nigeria, Kenya, Tanzania, and then we also used the United States as sort of a reference country outside of Africa, a reference context, if you will. So we got this information through surveying the project leads, many who are actually joining us today. Our first finding was similar to what Kristen mentioned earlier, in that the implementation outcomes really tended to focus on 3 things: feasibility, acceptability, and appropriateness. That across the projects, they didn't look at other outcomes. If you look at, Enola Proctor's taxonomy, they didn't get into things like adoption or implementation cost or sustainability or scale, that they really tended to focus on those fewer outcomes. We did find that there were 17 determinants that seemed to consistently come up, but there were fewer barriers than facilitators, which was an unexpected finding. I think we thought we would see more barriers. And even though we found relatively few determinants that sort of came up across these 10 cases, we also found that there was a limited set of implementation strategies that were used. There were actually only 17 implementation strategies out of a possible 73 or 75, really 17. But that these 17 strategies were applied 90 times or in 90 different instances, which meant that the teams were applying multiple combinations of strategies to address fewer factors. So you figure out an implementation barrier, and instead of applying one strategy to one barrier, they were actually applying multiple strategies to address one barrier, which can make sense when some of these barriers are complex. But maybe perhaps most interesting, as I mentioned earlier, there were actually fewer barriers than facilitators. There were not a lot of strategies focused on optimizing facilitators. The strategies that were selected, or strategies in general, tended to be strategies to minimize barriers. But when a facilitator was identified as a determinant, there was not a concurrent strategy applied consistently to optimize that facilitator, which I think it can make sense because barriers are kind of stunning and we want to minimize those. But I think we found that there were opportunities to optimize facilitators that typically were not addressed. So I think that as we see this increasing hostility towards sexual minority adolescents in Africa, the understanding ways to improve strategies to implement services that meet their needs become more and more important. And we hope that our paper will offer some lessons about what has been done. It can point the people to strategies and determinants that can help them streamline and focus, but also offer possibilities for things that we have not explored or given sufficient attention to. Thanks.
Thank you, Laurent. And I'm really glad you brought up the 2 points that I'm getting from, or 2 major points that I'm getting from your work. First, that you found less barriers than facilitators. That seems like a first to me. I think we go out there doing these formative studies and whatnot, just looking for barriers, right? And then the second thing is that even though at least one facilitator was found, or whenever facilitators are found, we are not thinking about enhancing the facilitator, boosting the facilitator. And really, and this is the point I also make when I'm discussing this with, whether I'm teaching a class or discussing this with other researchers, that implementation strategies are to address barriers, but they are also there to enhance facilitators. And you need to focus on both. You really have opportunities for making things better, for letting the intervention work better in the context that you are focused on by addressing facilitators and boosting them, while at the same time you're trying to minimize barriers. So thanks so much for bringing that up. And thank you to everybody for really the wonderful, unique work and really sort of blasting the door open for people to get more insights into the work that AHISA is doing, but also importantly, to be able to leverage the work that AHISA is doing and apply that to their own programs and research in adolescent HIV in different countries. So one thing I want to ask everyone is if you can briefly, thinking about the gaps and opportunities that you saw in your own project, what are some of the specific ways that we could catalyze the use of implementation science more frequently and more effectively in adolescent HIV? So what are some ways, based on what you learned from your own project, that we could catalyze the application of implementation science specifically for adolescent HIV? So what I'm going to do is start in reverse, that I'm going to have Laron answer that first, and then move forward.
What was stunning to me was that there were a lot of things that, at least in this study, that haven't been tried. So I think there's an opportunity to give some thought to, are there other ways to use some of these strategies that I think sometimes might be, given the context of funding that sometimes isn't robust, that I think you go with things that you can sort of accomplish in a particular time frame, but I think that has limited our ability to try these different strategies that really didn't show up in the cases that we looked at. But I also think this idea, which was, I guess you mentioned this too, figuring out how to enhance facilitators, that there's actually value in that. I think we can easily see the value in minimizing barriers, but figuring out why is this working so well and can we make it work even better is something that I think could help. I think in some of these cases, when these sort of cultural, political context sort of change, particularly as it relates to sexual minority youth, it's really assessing what can we do to sort of pivot. Because I think sometimes the combination of strategies made sense, but I think the strategy that you might use might actually change, need to change mid-study as the context sort of changes. And so those are things that aren't typical research strategies. You normally pick a strategy and you stay with it. But I think in this context, where things are dynamic, our strategies have to also be responsive and dynamic.
Right. Thank you, Laron. And as we're talking, we can bounce off what others are saying or what others have done and are sharing to address some of the issues that we had in our own project. So, for instance, Suja, is there anything you're drawing from what Laron is saying in addition to what you found from your own study or from anyone else? Yeah.
Sure. No, definitely. I mean, I think speaking about facilitators and barriers, to me, I mean, that's obviously the key. But I think to extend on what Laron said, it's like, especially programs that are implemented in the ground. Like I'm not thinking about patch studies because, for example, some of the AHISA studies, we are studies and we're research studies. But when these research studies get embedded into actual practice, when we have programs that are embedded, it would be great if those programs also used frameworks or models to actually collect the data, over the long term, because they have in some ways a longer term horizon, and then to learn about these barriers and these facilitators and what strategies actually work, using a data-driven approach, I think would be fabulous. So, I mean, that would not just be learning for those programs in the individual countries, but also to disseminate, as Jerry said, to other settings as well, because certain things can be adapted and used. So to me, yes, so more data-driven planning from the beginning would be great. I think a great addition using frameworks such as AIMS and others to just, I think, to really understand how to improve as we move forward. Back to you.
Thank you so much. And I mean, here you're talking about doing better implementation practice in routine programs as a way to improve the application of implementation science for adolescent HIV. Spot on. Thank you so much. I'll go to Jerry. What do you think? What did you learn?
Yeah.
And how can we change things?
Thank you. I'm going to build a bit on what Suja said, which is I think that in terms of data-driven programming, we also need really solid measurements of how we're evaluating some of these implementation outcomes. And I think there is a lot of effort in an individual projects to sort of develop those measurements, but we're not building a science of measurement for implementation as much. And I would suggest that if we could harmonize some of these measures when we have large consortia like the Patch Network or other, even AHISA, if we could agree on certain measures that are going to represent these implementation outcomes, we can really build a science to understand and compare findings across projects. If we say acceptability and you say acceptability, are we saying the same thing? And can we then have a way to use that language that can be disseminated more broadly and other people can use it? So this notion of harmonizing measures across different implementation outcomes, I think, would be a very valuable contribution.
Excellent. So your point basically is that as we can leverage on these large networks and beyond, the community of sharing and whatnot, to actually create more science in implementation science and help to make tools and measures that are user friendly. That would be a great opportunity for us to. And I think, given what AHISA has done so far, we're actually on that road already. And we're likely going to get more science being collaboratively produced among our groups. Thank you so much. So I asked Joe to make some comments.
Thanks, Nadia. I'd like to go back to a point that Laurent made about sort of facilitators. I think so often we kind of think about the needs and the problems and the diseases that it can really influence how we design studies and think about intervention development. And I really like the idea of thinking more about sort of assets, community assets, and like what are the strengths of a community, and really thinking about some of these positive things. I think in looking at how adolescents engaged in HIV research, it was clear that there were a lot of great sort of young people who had all sorts of talents that weren't really being put to their full potential, wasn't reached really. And so right. I think there's a lot of promise for, like Laurent said, let's look at these facilitators, things that are moving us in the right direction. How can we amplify those? How can we draw on community strengths? I mean, I think there's a lot there. That's sort of one point. The second point I'd like to make is about applied implementation science. So much of the time, there's really great ideas. And like Sue just said, they're not being evaluated formally with methods and frameworks, and yet they're getting stuff done. And so I think working with people who do get the stuff done to kind of have more rigorous evaluation and monitoring, there's really a great potential there. And I think that's an exciting part of implementation science moving forward.
Excellent. Thanks, Joe. So, I from what you're saying, we're thinking of community engagement, and in this regard, specifically adolescent community engagement as a strategy or as a means of, I'm careful using the word strategy in implementation science, as a means of having implementation science be better used in adolescent HIV. And then the second one, can you remind me of the point you were making?
The sort of applied implementation science. So like,
right,
get stuff done, but there may not
right.
be around it.
Applied implementation science. And for instance, in the HIV programs, I work in a lot of HIV programs, and there's so much that we're doing, but we are not doing it rigorously enough. And when you don't do it rigorously enough, you cannot really report it in a way that others can understand and reproduce. So if we put some rigor around that, there's so much more that we can learn and so much more that can be applied in our own context and in other contexts as well. So thanks for making that comment. Then last but not least, Kristen, help wrap us up with all of this. You started by giving us a profile of what AHISA is doing or not doing well in terms of the use of implementation science. What did you learn, and how can we use that to better the use of implementation science for adolescent HIV?
Great, thanks. Such interesting conversations and discussion. It was really fun to get to hear everyone's articles in these short little synopses. I wanted to piggyback or jump onto a few things. One was the idea of the implementation science strategies that are being tested. Like Laurent mentioned, there's this small subset that are really being focused on, and we found that in our article as well. There were the strategies that were being used very consistently across studies, and that they also really focused on kind of the interpersonal level. A lot of them were trainings and task shiftings. And one of the things that I think we could do, or places we could go, is to really think about testing implementation strategies at higher levels. things like systems or community levels. So looking at, mobilization and community engagement and ways that those can help us also maybe think about some of the later stage implementation outcomes like sustainability and penetration as we're moving bigger. Another one that also LaRon mentioned that also came up in ours was just this idea of adaptation. And something that came up with so many studies that we looked at were either adapting strategies throughout or adapting the evidence-based intervention. And so it would be really important, I think, to study how that adaptation is happening and what the outcomes of that adaptation is. Like, how does that actually affect the outcome and the implementation process? And then third is sort of jumping onto what Joe and Jerry and Suja were talking about, kind of this need for common frameworks and common terminology, and then also harnessing the existing knowledge. So there's, like Joe mentioned, there's so much out there that's being done. Like, how do we implement an intervention? People have to figure that out all the time. But whether or not they're using the implementation science specific language or frameworks, maybe not there. And so trying to figure out how can we arrive at a common vocabulary so that we can have these better, more informed and data-driven conversations that really move the field forward.
Excellent. Thank you so much, Kristen. Common measures or common frameworks, how we use them consistently, later stage implementation outcomes, and looking a little above the social ecological model, community, and I think policy levels in terms of where we are focused on our strategies and measurement of implementation outcomes. Thank you to all the panelists. Thank you so much for your time. Thank you to AHISA and to NIH and Fogarty for bringing us together. And I'll just put it out to all the people listening. Please go check out the supplement. It's open access in AIDS and behavior, and really to learn more about what everyone else is doing, including the members of the panel. I'm sure that you'll hear again from AHISA very soon as we give you more science and more output from the studies that we're working on. Thank you, everybody, and have a great day.
Hello, everyone. My name is Chisom Obiezo-Ume, and I am a doctoral student over at St. Louis University at Missouri. And I have the pleasure of co-facilitating today's session with Dr. Linda Gail Becker, which will introduce herself.
Yes, hi everyone. Welcome to this part of the satellite. It's so exciting to see you all, and I'm so delighted to be co-moderating this with Chisom. My name is Linda Gail Becker. I'm the director of the Desmond Tutu HIV Center here in Cape Town at the University of Cape Town, and I'm also the CEO of the Desmond Tutu Health Foundation. I'm going to hand back to Chisom to tell you what this segment is all about.
Great. Thank you so much for the wonderful introduction. So today's session is focused on understanding how can we really advance implementation science for adolescents and young adults in high HIV burden African countries in sub-Saharan Africa. And so today's session is really to explore opportunities to enhance adolescents' responsive approaches to HIV prevention, paying attention to policy-making processes that could affect adolescent and young adults' HIV prevention interventions. And I will pass it back to Dr. Linda Gail Becker to introduce our wonderful panelists.
Yes, and such an important topic. Actually, how do we turn our implementation science into real policy? And to discuss this evening, we have three excellent experts who do just this every single day of their lives. So I'm going to introduce all three of them, and then we'll launch straight into the questions and the dialogue. So first up is a good friend and colleague, Mo Archery. He's the associate professor in the Pediatric Infectious Disease Department at King Edward VIII Hospital in KwaZulu-Natal. And he obviously is very involved in children's programming, HIV, and rollout of antiretrovirals in South Africa. Mike Mbizo is the Zambia Country Director of the Population Council, where he provides research, scientific, technical, and administrative leadership and oversight in the programmatic area of reproductive health, HIV, and AIDS, and he truly is a leader in the area of implementation. And finally, the wonderful Eleanor Namasuko Magonga is a pediatrician and child health specialist at the Ugandan Ministry of Health AIDS Control Program, where she leads the National Program for Children and Adolescents Living with HIV. So an amazing lineup, and I'm very keen to hear what they have to say right away. So over to you, Chisom, for the first question.
Great. So really, and this question is open to all our wonderful panelists. So what role has implementation science played in developing and improving adolescent and young adults HIV policies and programs? And would like for you to really share some of the experience that you face in your country and your in your context. So maybe we can open it up to Dr. Eleanor.
Thank you very much, Chisom. This is a very important question. And I would like to start by giving my personal experience with implementation science research. Before I got involved or got training in implementation science research, I used to think that when you bring a few experts together in a boardroom and you discuss and come up with some ideas, you implement them, they constitute an evidence-based practice. With capacity building for me and my colleagues at the Ministry of Health, we now know what an evidence-based practice means. We've also seen implementation science research support us to translate evidence into practice. We now know that it's not important to have only the policies and guidelines, but more importantly, how you ensure that those policies and guidelines are implemented. And that's where implementation science research comes in. So implementation science research is very key to people who are doing HIV programming work, especially colleagues at the Ministry of Health, because we are doing this on a day-to-day basis. It's very important and highly recommended.
Wonderful. Thank you so much, Dr. Eleanor. So really closing that research to practice gap in capacity and building capacity. Dr. Mike.
Thank you very much. I would really like to echo what my colleague has just said, in that on one hand, we generate the evidence. We are able to see from the evidence what it means and what innovations there are. But for those innovations to make a difference, we are guided by implementation science in terms of HIV prevention amongst adolescents, because we do not have a magic bulletin. It requires our innovations and our thinking in terms of how we can tailor those interventions into appropriate programming. Programming for adolescents has quite a number of challenges, issues of stigma, issues of discrimination, a number of barriers. How do we maneuver and percolate and reach those that are marginalized, those are in most need, and those that are vulnerable? And so the implementation science is really a tool that helps us bridge the abstract knowledge, the academic knowledge, and service delivery, including evidence-based advocacy, as well as informing policy and strengthening programs for young people, for adolescents, including at community level, how best to approach the communities. Community engagement becomes very critical, very important. So this is yet one of the tools we have at our disposal, implementation science research. Thank you.
Wonderful. Thank you for sharing. And lastly, Dr. Mo, would you like to add on?
Yeah, just to echo. So I think one of the main things is really around, when we often generate this high-level randomized controlled trial data, it's created within a vacuum of a perfect environment. And we do know that, the health system is never perfect. And really, it's this transition from this vacuum of a clinical trial to actually reality. And I think one of the main things, and was echoed, brought up by Mike, is really around engaging with the community in how we bring this idea into reality. And when we speak about community, we speak about the broader community, which includes the healthcare workers, the systems that we work within, and also the community who are the benefactors of our intervention as well. And just to understand their perspectives and engage with the way in which we implement these and bring this into fruition. And I think one of the main things I've learned is really around that we do need to learn and listen to those responses, and you need to adapt, what we, going to do. And you may come into the situation thinking, this is the way I want to do it, but be able to adapt it to the, what the responses you get back from community is. Thanks.
So Mo, I'm going to pick up on that. I mean, I think that was a really important, you listed some of the stakeholders, and I think engagement with stakeholders is absolutely key and critical. But I'm going to ask you, how exactly do we go about doing that? Because I think it's easy to have the rhetoric, but so often key stakeholders are left out of the story right until the end, as you say, in that nice, implementation science controlled program. It comes to an end, and now they are faced with data or with a situation and have to respond. So how can we do this on the ground?
Yeah, I think so. So it does, span the entire spectrum of, research to policy making. I think one of the things is really around engagement with the community as early as possible, at the time in which we develop these interventions, and really, that we have that engagement. And just as one example, we recently looked at an intervention to try, to assist with adolescents transitioning from, pediatric care to an adolescent or an adult care system. And one of the striking things is, coming in as a clinician is really this paternalistic attitude to the care of adolescents. And one of the things, that came out very clearly from the, the engagement with adolescents as we were developing the interventions is that adolescents living with HIV did not only want to talk about HIV, they wanted the discussion to be about career development, family planning, STI protection, So often we come into these discussions with preconceived ideas. And I think one of the main lessons that I've learned is really around being able to listen to what the adolescents and the community is telling you, and adapt, your interventions and the policies that you are engaging with to encompass all of those discussions.
Great, thanks, Mo. So maybe I'll ask Mike and Eleanor, are there any stakeholders we've left out that we should have mentioned? I mean, Eleanor, I know you represent the ministry, for instance. Mike, a very important CBO that, really does extraordinary work. How do we engage these various stakeholders more effectively? I don't know if you have anything more to add to this.
That's a good question, my colleague here, what he just mentioned. What we have found to work is really early engagement of policymakers to get them to be involved as part of the team. One very good example we've heard in terms of our technical advisory team is to have representation from the ministry, to the extent that the chair for adolescent, the director, in fact, for adolescent health services in the ministry is the chair for our advisory board. And as well as community leaders, we have had community advisory groups and youth advisory panels, the YAPs. And the youth advisory panels are able to engage with other young people to discuss the language which resonates with the issues that affect them. And they meet with the policymakers, they meet with the director, and that dialogue, that engagement enhances the subsequent uptake. We have seen this work even during the time of COVID, where there were challenges in accessing services. And the ministry wanted to see if we would not have a break in both HIV testing as well as adherence to treatment. And some of those community voices from young people through that engagement, through that dialogue, through these advisory committees were able to get the voices and synthesize the data from the community voices and have them channeled to the ministry so that we can have, for instance, instead of facility-based distribution, we had community-based distribution, decentralization of services. Those are some of the things through implementation science we're able to do. Thank you.
Thanks, Mike. Eleanor, I don't know if you want to add something just quickly before we move to the last question.
Yes. So Mike has talked about the policymakers coming to work at the community level. And I want to talk about policymakers and the academia. I'll give a very short example of how we worked together to integrate NCDs into the HIV program. So at the Ministry of Health, most of the chairs of our technical working groups are from the academia. And that has been very strategic for us because when they come in to chair these meetings, they are able to pick some of the research gaps and they go back and implement these researches. And because they are part of the policy making groups, they are able to come back with the research findings and ensure that we are working together to have these integrated into our guidelines. And because of that collaboration, we've successfully been able to implement the research that the team did on integrating NCD work into HIV programming. So that collaboration between researchers, policymakers, and academia is very important. Thank you.
Agreed. Agreed. Last word over to Chisom, last question.
Great, thank you so much. So in terms of barriers and facilitators, what would you say are those factors that could ultimately influence a pathway to impact when we're thinking about the implementation science work that we do in our settings? And maybe just briefly mention a sentence, please.
Maybe I can start. I mean, the one thing is that you do need to have buy-in, both from the Ministry of Health, but also from the community. And I think that comes from engagement and ownership of the program. So that's my one sentence.
Brilliant.
Wonderful. Dr. Eleanor?
I want to agree with Mo that buy-in is critical. And I also want to emphasize that getting the voice of the recipients of care is very critical as well. Thank you.
Wonderful. And lastly, Dr. Mike.
Thank you. I agree with my colleagues. All I can add is to say, to have something that creates ownership by all the stakeholders within that continuum, community, service provision, research generation, academia, to all see it as a common problem and a common answer. Thank you.
Thanks, Chisom, and it's been such a pleasure to share this segment with you. We hope that everybody has really enjoyed this satellite. We certainly had fun putting it together at AHISA. We hope you've really enjoyed our series, which really digs down into these topics about how programming so important to be doing. And we look forward to engaging more with you in the next weeks to months. Want to thank the panelists. They were terrific. And of course, everybody at AHISA for putting this together. And have a good day, good evening, good conference.
Hi, I'm Susan Borkover, a public health advisor at the Fogarty International Center. On behalf of AHISA, I want to thank today's moderators and panelists. Your efforts really represent the collective learning of the Alliance around implementation science for the adolescent HIV continuum of care. Throughout today's session, we heard a lot of exciting themes. Raising youth voices in terms of research engagement and dissemination, and how we ensure that evidence is used. Relatedly, we also discussed stakeholder engagement more broadly as a way to link the research to policy and programming. This specifically highlighted the need to engage all stakeholders early in the research process, listening to what they need and adapting efforts accordingly, and then bringing these communities together so that they're all really hearing from each other. We also heard how the diverse voices and work of the Alliance have identified lessons learned from existing research and understanding where we go from here, including developing common language and measures, assessing underutilized implementation science outcomes, including adaptation, and testing interventions at the community and systems level. Eliminating adolescent HIV in high-burden African countries depends on the success of implementing evidence-based interventions to reduce transmission and improve treatment outcomes. This session and the supplement in AIDS and behavior highlights a path for doing this. Thank you for joining us today.